Sir, what is happening? I can't see my slides now. Wait. Yeah. So I hope everybody can see my slides. If there is any issue, please put in the chat box. And I think our oncology forum from oncology forum Nidhi will take care of the issues. Yeah. Mm. Okay. Mm. So we'll just start now. So the discussion today is going to focus on CAR T cell therapy and the clinical aspects actually. So our focus would be on lymphoma CAR Ts and a lot of new things have happened in India in the CAR T era, and something exciting has come up. We have CAR T approvals, Indian CAR T approvals, and just 2 days back, I got the information that another Indian CAR T after the ImmunoAct CAR T, which is Actelicel, another CAR T, which is the Immunil CAR T, has also got approval, and probably this is in the B cell lymphoma space. So this is the second Indian CAR T to actually get an approval. So let's focus on that also alongside while we discuss CAR T cell therapy in the clinic. So let me start with a few questions, and I would ask now how will I get the answers, because Nidhi, you'll need to make few people panelists whosoever is interested. I saw Karan Sood was there, and any Dr. Vineet Govinda, anybody who would like to join as a panelist, please come in and answer some of my questions if you'd like to. Otherwise, I would just go on and answer. So my first question is, which CAR T cell therapy are approved as potential second line therapy for patients with DLBCL following one previous line? So just remember, one previous line or progression within 12 months of treatment. So the options are the ones which are already FDA approved: Axicell, Lisocell, which is Breyanzi, Tisacell, Kymriah, Axicell and Lisocell, or all three. So this is again a trick question. All three are actually not approved after first line. Tisacell is the one which is actually approved after only 2 lines of therapy. And why is that so? Because the initial phase 1 data for Tisacell was encouraging, but when there was the randomized study, the study was called Belinda, when it compared SOC with, or the physician's choice or SOC with CAR T cell therapy, which is Tisacell, the outcomes were not different and Tisacell was not superior. So that's how Axicell and Lisocell, Axicell from Zuma 7, which is the DLBCL study post 1 line of treatment, Axicell versus SOC. So there Axicell actually won the battle. Same did Lisocell in the transform study. So Transform and Izuma 7, they established Axicell and Lisocell as the second line preferred SOC for those who have failed one line of therapy and or they have relapsed within 12 months of treatment. So early progression. So these are the two cells which are approved in this setting. Which Indian CAR T is now market authorized? So what is the immunoact cell called? It is called Actelicell. This is the name they have given it. So Actelicell is the immunoact cell, which is also called NexCAR19. NexCAR19. So the other cell which is also now authorized, and they have some more regulatory processes going on. The state FDA will have to clear it, and then only it will become, available for commercial use. The other cell is Varnim Captagene Autoleucel, which is the immunil cell. This has a Spanish origin, Spanish vector, viral vector. That's where it comes from, and it has kind of Clinimax platform manufacturing. Actelicell is a lot indigenous, and it is lot less automated, and it has a lot of indigenous effort in manufacture, and it's a humanized CAR T. Okay, so it is the humanized CAR T, Actelicell. Very important to remember this. With the toxicities and the concerns are different with these two kind of cells. So these both are actually now market authorized. Let's move forward. What is the long-term survival of relapsed refractory DLBCL with CAR T cell therapy? The answer to this is B, about 40%. Okay, this is the 5-year data from Zuma 1. Which of the following statements is not true about CD20 bispecifics? So what is not true? True. Did not show efficacy in patients with prior CAR T. So the data for BiTEs like glofitamab is post CAR T, and 40% of the patients who got BiTEs actually were post CAR T cell therapy. So BiTEs can be used after CAR T cell therapy. Complete response rates are 30 to 40%. And a good thing about BiTEs is that if the CR is durable and maintained, let's say at 1 year, then these patients tend to do well and they have durable remissions. They do require step-up dosing to minimize the risk of CRS. For glofitamab, which is a CD20 bispecific, you require a step-up from 2.5 milligram. So in fact, in the week 1, which is the cycle 1, day 1, you need to give obinutuzumab as a preconditioning to reduce the risk of CRS. So it occupies the CD20 well, and CRS is minimized. In the second week onwards, you start with 2.5 milligram dose, and then 10, and then 30. It's kind of a step-up dosing to minimize the risk of CRS. So this is for the bispecifics. CRS has been observed in half or more treated patients in phase 2 studies, which is correct. So, but B is not correct. It did show efficacy in patients who have got prior CAR T cell therapy. So which of the following statement is not true about Brexucell in mantle cell lymphoma? So the Brexucell data, the complete response rate is 68%. This is a correct statement. Yes, the CR rate in Zuma 2 was 68%. Brexucell is actually derived from Axicell only. It's called Tecartus, but it has a additional purification refining step, and it has a fixed proportion of CD4 and CD8 cells. So that's how it's different, but it is actually the same cell as Yescarta. So did not show efficacy in patients with high risk features or prior bender. This is, I'll come to this, whether it's correct or not. PFS was nearly 4 years in those who achieved CR. Yes, it was. The median PFS was 4 years in those actually who achieved CR. This did well, 48 months. PFS in those whose best response was only partial response was actually 3 months only. So CR is the goal. PR patients were not maintaining their responses too long. B, did not show efficacy in patients with high risk features is incorrect, because patients who had high risk features like high Ki67 or blastoid morphology, they also had similar responses. They did okay with Brexucell. Patients who got prior Benda, there was one small point here, who got within 6 months of CAR T, they did inferior because the T cell functionality was somehow altered. Somebody who's got before 12 months, they were doing okay. So this is the data from Zuma 2. You will see here patients who are CR, the blue line, the PFS is very strong. It's very nice. At 4 years also, they're maintaining, and this dip at the end of 4 years is there. But the relapses after the initial 1 year were very few. There were not many relapses. So they maintain, the CR patients do maintain their CR. The PR patients, on the other hand, they have a very short PFS. You see, patients with PR, the median PFS is only 3.1 months, and 24-month PFS rate is also only 18.8%, which is pretty low. So if you have achieved PR, don't be happy. In a mantle cell lymphoma. In a follicular lymphoma, the situation is slightly different. So which of the following statement is not true about CAR-T in follicular lymphoma? PFS was 40 months in Zuma 5. A is correct. No problem. Did not show efficacy in POD24 subset. It is actually whatever it is, I will tell you. Let's come to C and D first. And ELARA. Half of those. ELARA is the study for TISA cell in follicular space. Half of those in PR actually converted to CR later. This is correct. That's why I was saying a PR in a follicular lymphoma is not as bad, but in a mantle cell lymphoma, probably not a good thing. CR rate in ELARA was 70%. Similar was the CR rate in Zuma 5 follicular, about 75-76%. So responses are there, and they're also durable. PFS 40 months. And early progressors, B statement did not show efficacy in POD 24. Progression of disease within 24 months of initial treatment, which is generally bendamustine rituximab kind of treatment. If you have progressed within 24 months of that, the efficacy is still okay. The PFS same, about 40 months, no problem. So it does work in POD 24 also. So these are the curves from Zuma 5, which I've already explained you. The median I have explained you, 40 months. In POD 24 also, 40.2 months, no problem. ELARA, I have explained you TISA cell efficacy. About half of these partial responses in follicular with TISA cell, they convert into CR. So PR is not completely hopeless. You can still get a CR there. So before we move to the discussion on clinical aspects of the Indian CAR-T specifically, let's have little bit information on immunological basis of CAR immune effector cells. This is the broad term for all kind of CAR products or gene therapy modified, genetically modified immune cells. So similarities and differences between T and B cells, we should know that. So B cell actually directly recognizes and binds to surface antigens. TCR actually can only recognize new antigens when they are bound in combination with the major histocompatibility complex, or HLA. In humans it's called human leukocyte antigens, antigen, and presented by antigen presenting cells. So you require MHC association for these T cell receptors to bind to an antigen, otherwise they can't do it. B cells secrete antibodies, but T cells secrete cytokines and mediate cytotoxicity. So could we have best of both worlds, and we could have BCR, B cell receptor like specificity, but no dependence on MHC? We will not be MHC restricted. A cell which is not MHC restricted is cytotoxic and bind to any specific antigen like a B cell receptor. That would be it. So that is what the whole goal was when CAR T cell therapy was being designed. They wanted to combine these properties, and that's how they're chimeric. The fusion of these two receptors, B cell receptor and T cell receptor. Parts of both they have taken, the best of both worlds. So another important point, this we need to really understand well so we can understand why CAR T cell therapy works and how it came to work. So these cells actually, T cells, naive T cells, they can become activated only when two things happen. One is in association with an MHC antigen presenting cells, the TCR interacts with MHC and antigen, and there is recognition of that. Another step, which is called co-stimulation, which is extremely important for these cells to get activated, is co-stimulation. So a co-stimulatory pathway has to be activated, and in this case, in this diagram, it is CD28 and B7. So this is another pathway which has to be active, has to be done, has to happen for our naive T cells to become activated. So this is very important in the CAR T cell space. So mechanisms by which tumors can avoid immune recognition is very important. So why do we need to make CAR T cells? T lymphocytes are there, they can fight the cancer, but they don't, because these are the problems which are there, immunogenicity problems. Tumor is sometimes treated as a self-antigen, so T lymphocytes become anergic. So antigenic loss is also there. There is tumor microenvironment, and there are so many different factors and cytokines produced by the tumor which actually deactivate our immune system. So these are the problems. Another problem, CD80, CD86, these may be not expressed. The co-stimulatory pathway is not activated. So there is a problem. The immune cells are not able to recognize or fight it out, with the tumor cells. This diagram is also very important. You see in the most leftward diagram, you will see the T cell and the T cell receptor. You will see alpha and beta chains here, and then the CD3 part of the transmembrane and the intramembranous part of the T cell receptor, which is made of all these epsilon, delta and gamma chains, and these are CD3 basically. There's a components of CD3. There are three types of dimers, pairs, which actually work in conjunction to make the downstream pathway possible of activation. At the front is the alpha and beta chain, which is binding to the antigen, and then there is a co-stimulatory domain CD28 binding with a ligand like B71 and B72, which is CD80 and CD86 basically. This whole interaction has to happen for the T cell to get activated. And then the CAR T cell, look at it. It doesn't have these two chains. It is a single chain fraction variable. Where does this scFv come from? It comes from the B cell receptor, the front portion of the B cell receptor, which is antibody basically, immunoglobulin. And then there is hinge region and transmembrane domain, which have their own purposes. They're linkers basically. So they join the intramembranous component to the something which is the fork head at the front, at the front, which is binding the tumor antigen. So this is how the CAR T looks like. We'll go to the structure also in some time. So tumor microenvironment issues, other issues are also there. Tumor associated macrophages, so the Tregs, the MDSCs, myeloid derived suppressor cells, which can actually suppress, which are immunosuppressive. They don't let the immunity kill our tumor cells. Then there is expression of inhibitory ligands like PDL1. There must be many hematologists and oncologists in the meeting, and they must be very well aware that PDL1 pathway, the checkpoint pathway, is very much responsible for not letting identification of tumor cells by our immune machinery. Then there is secretion of these cytokines, which also is troublesome. Immunotherapy, let me tell you, is nothing new actually. It started way back in 1860s when actually there is a two German physicians, William Busch and Frederick Felison. They actually observed tumor regression in patients with erysipelas, which is a streptococcal infection. They saw that people who have this infection, they have tumor regression spontaneously. And then there was a Dr. William Coley in New York Hospital, and which is now Weill Cornell Medical Center now, New York. And he injected about 1,000 patients with live bacteria, streptococcal, and it was called Coley's toxin. And he observed that some of those patients actually had tumor regression. What was this? This was actually a form of immunotherapy. In fact, Coley has a Coley's Award now in his name. He is considered the father of immunology, actually, in the present era. So 1928, Dr. Raymond Pearl, he saw that people who have tuberculosis, they have less incidence of cancer. So that was an observation. Then he found that people found that BCG, when given intravesically, it can cause responses in the tumor. And BCG intravesical got FDA approval. This was a type of immunotherapy and mediated by a bacteria, bacterial antigen. So interferon alpha was another type of immunotherapy which incites an immune response. This was the first FDA approved cancer immunotherapy and cleared for hairy cell leukemia. Then IL-2 also, high dose IL-2. We know all of this for certain cancer. It is so effective, but it's very toxic though. But there was some 10-15% patients who actually responded to high dose IL-2 treatment. So what is the concept behind a chimeric T cell receptor, how it was found? So this starts around 1987 by a Japanese immunologist called Dr. Yoshikazu Kurosawa. And he actually combined these two, B cell receptor and T cell receptor, and he took actually the variable regions of of the antibody and combined with TCR derived constant regions. And this work happened in Comprehensive Medical Science Institute in Japan. And then thereafter, things started happening, and T cell engineering was actually started by an MIT immunologist, Dr. Michael Sedlane, who also worked in MSKCC later with Dr. Renier Brentians, and they basically started the program there for CLL and ALL CARTs. 1992, you see, he actually conceptualized T cell engineering, when a retroviral vector could actually enter the cell and insert a gene and cause a genetic modification within the DNA of the T cell. So this is how the genetic engineering actually started. Dr. Michael Sedlin led it. So another important scientist, he's from Israel, and Israel is one of the very I could say that he was kind of the mother of CAR Ts actually, and he actually worked on the T bodies, which is the initial primitive form of T cell receptor, the chimeric receptor. Initially, they conceptualized a double chain TCR, and which had a component from the B cell receptor, which is the VHBL region, and the constant regions of alpha and beta TCR chains. This was alpha and beta regions, but it had a very poor transduction efficiency, so it could actually never come into clinical use, but it was conceptualized there. Thereafter, in 1993, the first generation car was conceptualized and designed. This actually had it used only a single chain fraction variable from the B cell receptor and the CD3 zeta component of the T cell receptor, which was intramembranous, intracytoplasmic. And they combined these two. And thereafter, the first car was designed. So this is another component of the history. In 2002, somewhere in MSKCC, they thought that maybe something more is required. The CFV and this whole concept is great, but it's not working in the clinic. It's not working preclinically. It's not expanding. So they added a co-stimulatory domain, because co-stimulation is a very important integral path which is to be followed for T cells to be activated. So they incorporated CD28 into this whole, chimeric receptor, and they found it to work better. Lymphodepletion. I get frequently asked by so many, of my colleagues that why lymphodepletion is required. Yes, it is. It is required for the expansion of CAR T cells, and how we'll study that also in this very presentation. In 2004, there was another group working in St. Jude's. This was Dr. Dario Campana's group, and he conceptualized that not only CD28, CD41BB is also another co-stimulatory ligand which could be utilized, and it can also work similarly and cause co-stimulation. So the first initial trials of CAR T started in 2006 in MSKCC. Dr. Brentians was leading it, and Dr. Michael Sadlane's group, and they used the CAR Ts, and they subsequently improved it. And in 2011, they reported that some CLL patients and ALL patients actually could achieve a complete remission when they used these second generation CARs which had the co-stimulatory domains. In 2012, we all know it was kind of a watershed moment when the first pediatric patient of ALL was treated in this study, University of Pennsylvania, Dr. Carl June's group, and she achieved a complete remission. She's still alive, and she is kind of the flag bearer for the CAR T cell therapy all over the world. She has a foundation in her name. So in 2017, the grand step came about when Kymriah was approved by the FDA for leukemia, ALL. So 2021, now we have so many more approvals. We have myeloma CAR Ts, we have other lymphoma and ALL CAR Ts. So the space is expanding like anything. So let me, again define CAR T cell therapy. What is it? So CAR T cell therapy is basically a name given to chimeric antigen receptor genetically modified T cells. The whole process we discussed, how we genetically modified it, how the historical perspective, how we came to CAR T cells, and these are actually they recognize specific antigens, and they don't need MHC they don't need antigen presenting cells to get activated. So they actually can bind a specific antigen which they have been designed to target, and they will cause activation and proliferation eventually, and durable destruction of malignant cells. They have the capacity of expansion and persistence, which is why it is called a living drug, since they can persist for very long periods of time. So these are generated generally right now, as of now, they are generated from patient's own cells. So, but the day is not far when we'll have more of the shell CAR T cells also. But as of now, all the products which are FDA approved, they're autologous. So this is the pathway. The T cells are isolated from the patient by a procedure called leukapheresis. They are engineered to express the chimeric antigen receptors. Then they are grown and expanded in culture, and then these modified T cells are infused into the patient. So why did we need CAR T cell therapy? To my mind, probably we need to actually harness the T cell in better ways. What we were doing via allogenic stem cell transplant, and we still want to do, because it is standard of care for so many diseases. It still does not dissociate the toxicity from efficacy. That is a problem. So maybe you could call that CAR T cell therapy maybe a refined form of transplant. There is a paper also on this very topic, whether it actually can be labeled that. But yes, that's debatable. But yes, we did need to harness T cell in better ways than a transplant. A transplant stays, but CAR T cell therapy is a purified, refined form, a refined technique, which can actually help in situations where you know other therapies are not available. So there was an unmet need which was met by CAR T cell therapy. This is a frequently asked question, which I get asked very often. Why conditioning chemotherapy is required before CAR T? This is very important to answer this. Lymphodepletion actually is not to kill the leukemia or the lymphoma. It actually is to provide these homeostatic cytokines, which are IL-7 and IL-15. These actually create that lymphopenic environment for the lymphocytes to expand. So these cytokines make it favorable for CAR T cell expansion. That's how they work better. They expand better. They have better responses. This is some of the data which shows that if you use flu-cy conditioning, your CAR T expansion is significantly better. You see the red line with flu-cy, the persistence is much better. So that's how flu-cy is important. Practically, we schedule the lymphodepletion 3 to 5 days prior to the infusion. Generally, it's a flu-cy conditioning, 30 mg per meter square 3 days, 500 mg per meter square 3 days, flu and cy, and then there is a rest day, and then we proceed with the cell infusion. You know, you could give the cells anywhere between 2 and 7 days of the conditioning, but we give it within 2 or 3 days generally. So patients who have very low lymphocyte count, absolute lymphocyte count of 100, you could argue that these patients are already lymphodeplete. So why do we need to do the lymphodepletion? So that's okay. If you have very low ALC, these patients may not need lymphodepletion. So has CAR T transformed diffuse large B cell lymphoma in any way? Look at the real world data, Scholar 1 registry data, compare it with Zuma 1, cross comparison, not a great thing to do. This is all, I have to show you, in terms of the real world data. 2-year survival rate in Zuma 1, 50%. Scholar 1, which is non-CAR T approaches in relapse refractory setting, 12%. 2-year survival rate. Response rates, CR 22 versus 7, ORR 72 versus 54. So it does seem to be doing better than the usual treatments. Also 73% reduction in the risk of death. And also responses are much better with CAR T cell therapy in refractory DLBCL. This is the curve from the update from Zuma 1, 40% about the survival PFS, and when you look at the disease specific, it is around 50%. This is a salient findings from the Zuma 1 study. Overall response in DLBCL, the relapsed refractory cohort, is 83%, CR rate is 58%, EFS at 5 years 31%, disease specific survival 51%. I always make it a point to remember these. This is what is required to counsel your patients. So we need to separate the reality from the hype. Very important. So we need to really tell patients what we are expecting here. What is the expected CR rate and what is the expected long-term cure rate? So everybody does not get cured with CAR T. So whenever you're taking up a patient for CAR T, we need to make a point and discuss what are the pros and cons. Is the survival, is what we are looking at with CAR T cell therapy, is it acceptable to you? This is what we're looking at. This is the data. OS 40%, and in patients who achieved a CR, 64% are alive at 5 years. So also importantly, CR mostly is achieved by week 4. It is not so much as follicular, where half of the PR patients also achieve a CR later. So most of the CRs you will get by week 4, and with the Acteli cell, the Indian CAR T, even more so. I speak with the investigators and they also feel the same. CR generally you would achieve by day 28, and if you're not achieved, it is something to be concerned about. The CRS rate is 93%. Practically everybody has fever, and 11% have grade 3 and above. And ICANS 64%, 30% of one third of ICANS with Zuma 1 is, Axicell is grade 3 and above. So, why it is called a chimeric antigen? Because, as we discussed, B cell receptor, T cell receptor. Components of both have been taken. That's why it's chimeric. So there is a single chain fraction way SCFV, which is the front of the battle front of the CAR T, and the intracytoplasmic domain is the CD3 zeta, which is there inside, and then there is a transmembrane domain. This is how a CAR T is made. Now, there is also hinge region made of different, various different domains in different products. But the important ones are these, which we are discussing right now: the antigen binding domain, the CFV, then the co-stimulatory domain, which is mostly the CD28 or CD41BB, commonly. Then the CD3 zeta, which is the intracytoplasmic activation domain, signaling domain. CAR T designs have evolved. Yes, there are third generation CAR Ts which have, which seemingly would be more active. They have two co-stimulatory, domains there: CD41BB and CD28 together, or CD28 OX40 together. But as of now, there is no data to suggest that third generation CAR Ts work better than second generation CAR Ts. So we are there. The commercial products, all the FDA approved ones are second gen cards, and there is no, as of now, no indication that third generation cards would work better in any way. And there are newer and newer designs which have genes encoding cytokine production and other factors. The CD3 zeta domain also is being replaced now with other factors which causes less of cytokine storm. So the design is ever evolving, and not only T cells but other type of cells like NK cells, gamma delta cells. People are working with so many different cell types and modifying them. So these are the various lymphoma CAR Ts which are there and available. You can see the transmembrane domains also. There's information on that, but you will see here the CD41BB versus CD28 CAR Ts. You will see the Brexu and Axicell are the CD28 CAR Ts. You need to know which is a CD28, which is a CD41BB, because the toxicity profile, the persistence, the expansion, the kinetics of both are different actually. So this is some of the from the trial data. You can see here the CD41BB, Tisagen, Leclucil, Tisacel. Another CD41BB is Lisocel, Breyanzi. So Breyanzi is the data from Transcend NHL, again LBCL, 53% CR. Brexucel for mantle cell lymphoma, 67% CR. Yescarta, 58% CR. And for Kymriah, again about 68% CR, and overall remission rate is about 81%. Actelicel, which is the Indian CAR T, the overall response rate is at about 70%, and the CR rate is about 40%. These are the co-stimulatory molecules. We need to know these. Remember CD28 and 41BB. CD28 will expand faster and they will dip very fast. But CD41BB will expand later, slower kinetic, and they will persist. And the toxicity, early toxicity, CRS, generally the CD28 CAR Ts, they are considered to be more, having early toxicity, more CRS. So this is the, time plot. You will see the CD28 CAR T cells, they expand generally within few days, 3 to 7 days, and then they peak rapidly and go down. But the 41BB, so 1 to 2 weeks they peak and then they persist for longer. But as of now, I can't say that the cells which are persisting longer, they are acting better, or they have more responses, or their responses are deeper. As of now, we can't say that, and they seem to work as well actually, even with ALL. So let's come to the Indian CAR T cells. So this is very important collaboration, and here we learn why collaborations are important. And as Indian doctors and Indian physicians, We need to collaborate with researchers so we can think of new strategies to treat our patients, and maybe have better treatments available and more accessible treatment. They have really done a great collaboration, and they have done it. So I must commend them, I must congratulate them, and we all should. So this is one picture, showing all the gentlemen who were involved in the process. So these are the indications as of now. So the initial indication approval they have got is for 15 years and above. B cell lymphoma, including all types of B cell lymphoma like PMBCL, follicular, MZL, MCL. So MCL, MZL, from some of the data from AxiCell, we know that MZL does a little worse than the responses are less durable than MCL. So from Actelicel, I don't know the bifurcation of these lymphomas, how they did with respect to the other, but these are the indications which are there, and obviously B cell ALL is also one of the approved indications. There are some inclusion criteria. You don't have you should not have an active infection, which is understandable. No established neurological problem, active CNS disease. All these are exclusions. For the ALL cohort, they had blina use as an exclusion. So these are the interim results. You look at BALL cohort, CR 71%, updated data shows about MRD negativity of 75%. And they did include a lot of patients with high burden disease. So in ALL, the efficacy was very good. B lymphomas, decent, 65% overall response rate, 44% CR rate, 21% PR. What was a matter of discussion between the Immunac team and us clinicians is what happens to the PRs. So as of now, the discussion, it took us to a point which said that PRs actually are a concern. They will not spontaneously convert to CRs unless we don't act. So for us, it's early days using this particular cell. So we have at our center, we have treated 2 patients and we have 2 planned. So this is a pre-infusion checklist, and these are the tests which are required. Is very similar to planning for a transplant. The workup is very similar, but you do want to do the T cell in the T, NK, B cell subsets, immune cell subsets. You want to keep a record of those pre-CAR T. You want to keep a record of immunoglobulin levels and the organ function, because you will need to follow these later. So all these are kind of important. You also need to halt your steroids 24 hours prior to the apheresis. And this is the Actelicel recommendations, the Indian CAR-T recommendations on washout periods is slightly liberal, I felt, because they took into account our problems, our limitations are as Indian doctors. So their washout periods are slightly more liberal when we compare to the American counterparts. The immunotherapies like blina, they have they seek a washout of 4 weeks or so, or 5 half-lives. This is the complete checklist from the package insert. Steroids, immunosuppressive drugs a week before, steroids 24 hours, TKIs, hydroxyurea 24 hours, cytotoxic drugs, weekly maintenance therapies, they should be stopped 1 week prior to apheresis and infusion. CD20 therapy 4 weeks before or 5 half-lives, if there is any other immunotherapy. CNS disease prophylaxis 1 week prior, radiation therapy 1 week prior. For leukemia patients, they want a time gap of 28 days between DLIs, and the infusion. And the patient who is post allogenic transplant, they should be off immunosuppression for at least 2 weeks. So all these are important to remember. The package insert is there for us to read and remember. This is a CRS management guideline. So fever, hypoxia, hypotension. Just remember these three. If persistent fever is there, 2-3 days, give the tocilizumab. And then subsequently, if you have more problems, hypoxia, hypotension, and more features of CRS, you will need to give some steroids also. And then comes a role of anakinra, other drugs which are used for severe CRS. And this is the checklist, the guidance animation from the package insert of Actelicel, which is the Indian CAR-T, the ImmunoAct CAR-T. So how does it compare with the other US counterparts? The overall response rates and other cells, TISA cell 50%, Axi cell 83%, Liso cell 54%. Actelicel, Indian CAR-T, 68%. So it is a cross trial comparison. It is not a randomized data. So we can't absolutely compare them, but they are active. This cell is also pretty active and it does deliver. Adverse effects, the CRS is about 67%, grade 1 and 2, grade 3 is 5%, ICANS was none, which is a one aspect of this humanized CAR T, which helps us, and it tells us that it is safer. Hypogammaglobulinemia in about 38%. We need to give IVIG replacement. Please discuss this with your patients when you're planning CAR T cell therapy. Tell them that there's a half a chance, 50% chance that you will require IVIG replacement for a long time, even post CAR T. That's an additional cost, additional burden. This needs to be discussed. Safety data, as compared to the other CAR Ts. The blue line is the Actili cell. You see here, the grade 3 CRS practically negligible, and in the leukemia cohort, it was 20%, but in the lymphoma cohort, practically none. No patient had grade 3. Neurotoxicity, practically none. So no incidence of ICANS. So it's a safe product as compared to the US CAR-Ts. So in the Indian setting, it does have distinct advantages because it has been designed. This car has been designed for Indian roads, as we say. So safety comparison again, the neurotoxicities you see 0% versus 20, 28, 25. Well, in the other cells, hypogammaglobulinemia 53% of T cell, Axi, Brexu, and Liso, they have 0 and 14% Brexu and Liso, but hypogammaglobulinemia about 40%. So this needs to be remembered and told to patients and their families. ICU admissions are lower. So my initial consent form, I do remember modifying it because the ICU admission rate in Actilicel is lower, which is a good thing for us. But otherwise, 1/3 of these patients in the US, they land up in the ICU. Healthcare utilization, IVIG support, they have not reported, the US counterparts, but our Actilicel has reported it's at about 40%. Tocilizumab use 45%. So they have been very proactive with using Toci, I believe. So total patients who got is 39%, 21 out of 54 patients. And the cutoff for using, I had a discussion with Dr. Hasmukh also on this, and he told me that less than 600 milligram per deciliter is where he would actually consider IVIG replacement. That's what we are also following now at our center. So this is the kinetics of this particular, this is of CD41BB CAR T. So obviously expansion phase would be slightly later, 7 to 14, and they persist. They have shown durable persistence for about 6 months or so. Also, it was safe. The replication competent lentivirus was not detected in any of the trial participants. So safety was documented. This is a scenario from our own clinic, ABC type of DLBCL, MYD88 mutation. I make it a point for testing some of these mutations, 79B, MYD88, before I embark upon treatment. It really informs us of the choices. This patient was very symptomatic. We stabilized her with acalabrutinib and lenalidomide. She became better, and subsequently post CAR T cell therapy, she is our second patient on Actelicel, and she has managed to achieve a complete response on day 28. The first patient is a partial response. So I have one PR, one CR from 2 patients. So this is the Immunil data, which also we need to be aware of because this is the other player. If Immunoact is the father of CAR T in India, this is the mother. I say it fondly. And the phase 2 study, Imagine study, very well done. They've made a huge effort again, similar to Immunoact. This study actually has included BNHLs and BALL, and they have treated, so these patients. This is the patient profile, and these are the inclusion exclusion criteria. Very similar to what the Immunoact study had. So this is the efficacy. The initial efficacy, 76.5% responses in BNHL. Because there's a lymphoma discussion, I'll focus on lymphoma. 7 out of 9 responses. Overall response rate again 10 out of 11. By day 28, by day 90 is 7 out of 9. So very active CAR T. I am still not aware of the actual CR rates. So they will need to tell, and they have that data, and they tell me that it is reasonably good. So this is the this is called a swimmer plot, and you can see the green ones are actually CR, and these are with CR with B cell aplasia, the dark green ones, and the light green ones are CR without B cell aplasia. B cell aplasia is something we monitor post CAR T cell therapy, and we monitor with flow cytometry the immune cell subsets and the B cell recovery. So B cell aplasia is a good thing because the CAR Ts are active, that means, and they're persisting, and they will lead to durable responses probably. So these are quite a lot of CRs here, and CRs with B cell aplasia also quite a few. They gave a fractionated dose of infusion, so in 3 parts. So that's how they were able to reduce the CRS and ICANS also. So you see here the CRS is at 4.3%, which is way below, the 60.8% grade 1, way below the axi-cell and TISA cell. They are at 90%. So they did control this side effect by using a fractionated approach. ICANS grade 1, 4.3%. Treatment related mortality 4.3%, 1 out of 23 is the mortality. CRS, tocilizumab use is 39%. Similar to they were at 45% immunoact. So this is at 40% again. So then again some data on the we have already discussed the responses in lymphoma, 10 out of 11, which is pretty good. It's the same data actually. There is some experience from Vellore also, and my friend and colleague Dr. Uday Kulkarni, they're doing a wonderful job there. And this is the data which they showed in the SACT meeting 2023. 3 patients were DLBCL, and there was one CR, and for 2 patients the response assessment was actually awaited. So out of 3 which they treated DLBCLs, 1 was in CR, and I'm not aware of the fate of the other 2, but I'll subsequently ask him. I'm curious. So which early relapses can actually go for an autologous transplant? This is again a FAQ. So is every patient eligible only for CAR T? Somebody who is primary refractory or has relapsed within 12 months of therapy. So with POLA coming in, POLA fraction, that proportion is also going to go down. So you would have less of primary refractory because POLA R-CHP can actually prevent early progressions. So that will slightly change the dynamics for CAR T-cell therapy in India now it being available. Which early relapses can go for auto? And this is a slide showing the CI-BMTR data that patients who have early chemotherapy failure or late chemotherapy failure but are in PR or CR, they actually, or PET PR, they actually do reasonably okay. They can also achieve a PFS of about 40%. So chemosensitive or CP patients, especially who are in CR post salvage chemotherapy, you could still consider autologous transplant for these patients even if they are early relapses. But yes, this is the SOC still as per the randomized data, is CAR T, but which patients can still go for auto? This is one subset. Bridging therapy, very important discussion. Bridging therapy is the therapy which is administered between the leukapheresis and the infusion. That is the bridging therapy. That is the bridging, time. So how do we bridge patients? Why do we need it? Because it's an aggressive disease. Most patients are symptomatic. We need to reduce the symptoms. Also, high disease burden actually, has poorer is correlated with poorer outcomes of CAR T cell therapy. So we need to reduce the disease burden. So we need to choose treatments which have reasonably high response rates, reasonably low toxicities, and we don't want any treatment-related mortality. And cytopenias because of this treatment should also not be prolonged. So you don't want to give aggressive salvage chemotherapy during bridging period. You don't want to make the patients ineligible for CAR T cell therapy. So is achieving a CR, you give a bridging treatment and you might actually end up achieving a CR. So what to do then? So this subset from Juliet study, 5 out of 7 patients who actually were in CR prior to infusion, they were taken off protocol, and they actually also did okay. And they also had rapid expansion and persistence of CAR T cells at 2 years. In fact, from ASH 23, there is data on patients who were in CR before getting CAR T, and the outcome in those patients also about half an hour. So about, they have durable responses in about half of those patients, and they do similarly to patients who are in partial response. But obviously you don't want these patients, in CR. If you have a CR, what would I do? I would be confused because I would not never get to know what the response to CAR T was. So the dictum could here be short follow-up or other, maybe a transplant, but it's a very difficult question to plan or ask yourself when you have a patient already planned for the infusion and you've done the leukapheresis. So this question is going to keep coming in our life, as and when this CAR T era goes on and forward. What are the options? Pola BR, Pola R, all these are options. Combined modality therapy, radiation, chemotherapy together, intensive chemotherapy, radiation, very important. Targeted therapies like BTKI and lenalidomide, venetoclax. I have relied a lot on acalabrutinib, lenalidomide, these kind of treatments, and I really prefer these treatments before CAR T. Now, Pola coming in, Pola also will become an important treatment. One of my colleagues had a patient who got Pola R and got into CR during bridging period. And then again, that difficult question is there. What should we do? Should we proceed with CAR T or do something else? So bites generally have not been used before CAR T. So we need to keep this out of discussion. They are still subsequent line after CAR T probably. So Pola as a bridging therapy. It's a very nice treatment because it doesn't have much toxicity. Elderly patients can also take it, and this doesn't cause too much of cytopenia. So this can be a very good treatment. And you look at the Pola BR data, the responses, CR rates 40%. Pretty brisk, very very good drug. And look at the activated B cell type of DLBCL, cell of origin based. You would find more activity there. The overall response is 91%. This is similar data in the upfront setting also for polatuzumab with the Pola R chip. There also ABC type seems to benefit more. Is Pola a better bridging therapy? It seems so based on this particular data set. And this is a review of bridging therapy. And you see what Pola BR does. RBP is Pola basically. So Pola BR. So it has higher response rates. Because it has high response rates, the reduction, because CD19 CAR T cell therapy patients who are lower disease burden, they do better, they live longer. So their risk of death is also reduced by using this kind of bridging therapy. So there is a 42% reduction, in this particular subset who has responded to bridging therapy. And the bridging therapy responses were higher with radiation and Pola VR. So just remember, radiation is also very useful bridge for CAR T cell therapy. So I really, in one patient, in fact, I've used it also. So this is on bridging. Leukapheresis. So my transfusion medicine team keeps a very good track of, the leukapheresis, salient points, and they keep a tab on it. This is the washout periods. The washout periods you will see in the Acteli cell is slightly more, liberal. But yes, this is the washout periods recommended for the Western CAR Ts. Bendamustine is one drug which we need to avoid before giving CAR T cell therapy. In fact, as far that the bendamustine is far out from the CAR T cell therapy is better. You looked at the mantle cell data. There, patients who got 6 months, within 6 months bendamustine, they did inferiorly. So we need to avoid this drug when doing CAR T cell therapy. But in the bridging time, when we have done the leukapheresis, it's okay to use Pola BR, and it's a very good bridging combination. So the specifications of leukapheresis, if you have this kind of ALC, more than 1,000, you can do 1.5 volume processing, and you can get your desired 1,000 million CD3 cells, which you generally would require. Acteli cell, Immunoact would want 2,000 million cells, CD3 cells, to manufacture their product. More than 100, if per microliter, you need to do 3.5 to 4 volume. If it is 100 cells per microliter, you probably will need to do 2-day collection. So this just gives a good idea to the blood bank how the collection should be. What factors can affect the ALC can, steroid use can, checkpoint inhibitors can, bendamustine exposure can. These are the factors which can actually change your leukapheresis schedule and leukapheresis planning, affect that planning. So please, one thing, just try to avoid chemotherapy and cytotoxics before your leukapheresis, and keep your T cells healthy. That's how because it's a CAR T cell is a drug different for each patient. It's a personalized drug. So the drug concoction will be different for different patients, and there will be host factors which will come into picture when you have those responses. So acute toxicities can be CRS, ICANS. We have heard of these terms. Then cytopenias, which is the hematological toxicity, ICA HT. So acute infusion toxicity, that's rare. And then HLH can happen, anaphylaxis, coagulopathies can happen. All this needs to be monitored. CRS is a supraphysiological response following the activation and engagement of T cells. It can present with fever, hypoxia, hypotension, capillary leak, end organ dysfunction. But this is the grading system: fever, hypotension, hypoxia. These three factors, and then you can grade your patient into grade 1 to grade 4. This is that chart, ASTCT grading system. So, but remember, these are the not the only features. There can be many others. They can be fatigue, severe fatigue, myalgias, arthralgias, rash, nausea, vomiting, tachycardia, elevated, coagulation problems, renal problems, liver dysfunction, neurological issues. All these can be there. So it can be non-specific. So just keep your eyes open to CRS. And this is the management. Anything beyond, persistent grade 1, you give the TOSI. And grade 3, you give the TOSI and DEXA and high dose methylpred for the grade 4. And you shift to ICU once it is grade 3. And your ICU needs to know what is going to happen, how is it to be managed, how fluids are to be managed, because they have kind of capillary leak kind of situation. ICANS, we do the ice score. This is ice score is available online. I use that chart. I told all my residents and nurses to do daily ice score monitoring. And also importantly, we monitor the handwriting every day, and the same sentence, 2 3 sentences we make the patient write every day, and we track it, the circadian rhythm, the arousability, the mental status examination. All that is very useful. But simple things, ice score and the handwriting, very important. So this is the grading of ICANS. So this is sometimes you will need to do neuroimaging also, EEGs also. They can be seizures. So you see that grade 1, in grade 1 you have the eye score disturbances early, handwriting disturbances. This is to be monitored, because once it is very severe and not identified, you will land up into a big trouble. This is the management. So the dexamethasone is given for grade 2, 10 mg 6 hourly, tocilizumab, and if there is concomitant CRS, and methylpred is given high dose, for 3 days, high dose methylpred 1000 milligram is given for grade 4, and the management is mostly in the ICU. So this is the management algorithm. Aggressive fluid administration should be avoided in patients who are having CRS, because they will have pulmonary edema. And tocilizumab, you can repeat doses 6 to 12 after 6 to 12 hours. Then anakinra, the product package insert from Actelcell, it mentions 100 mg subcutaneously daily for 7 days. They are using it. So it is for the CRS and ICANS, because TOSI will not work in the brain. It doesn't have activity there. So my take-home message now: CAR-Ts have finally arrived in India. Feasibility and safety has been proven. There will be a learning curve, but indigenous CAR-T cells are a lot cheaper, and they are still there with us. But still, I would say they're nearly inaccessible for many patients. So the cost needs to come down more, and we all are hoping that happens. Awareness about patient selection, toxicity, and management is crucial. Counseling is key. We can't hype the treatment also. So we should not hype it. We should tell the truth. We should be transparent that this is what the data is. These are the CR rates. This is the expected long-term survival. Only after understanding each of these aspects, your patient should be treated. And because the media hype is huge, just take care of that. Be very transparent, and very not if you look too excited about the treatment also, it might bring unreal expectations to it. So real expectations are okay, but it should not be unreal. Your expectations should be reasonable and correct. That's acceptable. So but CAR-T storm is likely to take over India. And transplant, don't forgo it. It is still a strong option for many of our patients. So chemosensitive relapses, please remember, those are in CR. They could still be auto-consolidated. So thank you, and let's have a more interactive discussion now. I'll be happy to take questions. So Nidhi, can you coordinate further?
So I'm looking at the chat box and I am waiting for questions to come up, which I can share with you.
Okay.
Yeah, so there is a question coming up.
I
Uh,
think whosoever is asking, you can put him in the, put them in the panel for a discussion.
but I think you have raised the hand.
I have
Yeah.
no. Wait. I've removed it. I could have myself.
Yeah, but from attendees, I'm not seeing any question right now coming in.
Are they able to hear? What?
Yeah, of
Yeah,
course.
yeah.
But it was a brilliant lecture and very nicely and extensively covered. So
Thank you.
probably that's why I'm not seeing many questions because you answered most of them. Yeah,
I hope to
yeah,
answer.
I think so.
But I would, Karan is there. Karan, I will make you panelist. Let's have a discussion with you. Wait.
Yeah, Dr. Karan Sood?
Yeah. Let me make him panelist because I know him. He was there in the lymphoma preceptorship as well as the leukemia academy here.
Yeah, yeah, he's here.
Yeah. So Dr. Sachin, I think I know him. Let me make him also panelist. So can you hear me, Karan and Dr. Sachin? I made them panelists now. Who else I know? Let me see. I think I know Dr. Akanksha probably. She's a hematologist, I think. Harish. Are they able to talk actually? Because I can't hear them.
Yeah, they have to unmute themselves.
Yeah. Maybe they are facing some technical difficulty, because.
You can write in the chat box if they're facing any difficulty.
You're audible, sir. It's an
Okay,
excellent,
Harish.
excellent. Thank you. Yeah, yes. So, this one. So we have started CAR-T for myeloma also as an anti-BCMA product from
Great.
Origin. This one we are starting leukapheresis for one of our first patients this week.
Oh, that's great. That's great. Congratulations. That's great. So this is the part of the clinical trial.
It is a part of clinical trial.
Oh, that's great. That's great. That's great. Congratulations, Harish. Yeah. Great.
Okay. Thanks.
So I think there is some questions. So can you give
Well,
some
I have
point
a
of
question
trucks?
actually. So this
Okay.
our Acteli cell is a, I thought it was a third generation CAR T cell.
No, it
Is
is
it
also a
correct?
second generation CAR T, not a third generation. No, it is not third. It's a second gen.
Okay.
All commercial CAR Ts right now are second gen. No third gen CAR T.
Okay.
So there is. So if there is any question, Dr. Sachin, would you like to say something? Okay, I think he's muted. So there are some questions in the chat box I see. So any idea about trucks and its role in lymphoma? Trucks are T cells, redirected for universal cytokine mediated killing. Trucks. So they have a something which can produce a cytokine to prevent immunosuppression, and they can cause more cell kill. So I am not aware of any any commercial product in development which is a truck and for lymphoma. But yes, there are new gen CAR Ts. Maybe you can call them fourth gen. But I don't think there is anything in the horizon which I'm aware of, which is entering the clinical domain. I'm not sure whether they are more active or not. But yes, they are presumed to be more active and more they would be more cell kill. R-Pola-ice is the standard bridging therapy in Europe for lymphoma. So in India, I don't think there is any standard therapy as of now. People are using anything. I have to my mind, for me, ice would be, for me, for my set of patients, ice is not something I am very comfortable with, because I don't want any toxicities or delay in treatment because of the cytopenias. I don't want any treatment related problems. So I am still with some lower intensity treatments. In fact, if you look at the data, I showed the data for bridging therapy. Patients who got high dose chemotherapy, which is a salvage like ice, they did inferiorly. Their outcomes are also poorer. So I don't think I would use ice there. I would use radiation as a bridge, or I would use Pola R or Pola BR or acalabrutinib, some lower intensity treatments. This is what I would prefer. So another question is, sir, is it too early to say that polatuzumab may reduce the transplant dependency and CAR T dependency? Okay, I think Pola comes at a cost. So for some patients, this cost will be bearable, some not. So, but yes, I would say that you are driving home a point actually. So I think there would be some change in the dynamics now. With Pola coming in, I think it is okay to say that there would be some patients who would not need it in the Pola would reduce the need for transplants and CAR T if it comes in a big way in the upfront setting, which I think it is slowly entering. But yeah, cost is again a factor. But when you do the cost analysis for CAR T versus Pola R-chip, Pola R-chip actually might score. So for the activated B cell type or the high risk DLBCLs where you would expect that relapse rates would be higher, so there you would tend to use Pola R-chip and not let them need the CAR T cell therapy later. Probably you are right in that way. Yes, it's a very good point actually. Very good point. So if there is any other question, we'll be happy to answer. So I think Nidhi, I think if there is no other question, we can close the session. And
Sure.
I will just write my mail ID somewhere in the chat box. And so any you all can mail me and ask anything.
Yes.
So this is my mail ID in the chat box. If there is any question, I would be happy to answer. Thank you. Thank you, everyone, and good night. It was great talking to all of you. Thank you.
Dr. Prashant, I can see 3 questions coming here.
Okay. Tell me. I have answered 3 actually. The ones which I can see, I've answered. Are there any more?
No, okay. After those, no more, I think.
I've
So,
answered these.
yeah, so we'll end the session now.
Yeah.
And yeah, but it was a really nice session, very nicely and extensively covered. So,
Thank you so much. Thank you.
thank you
Thank you,
for
everyone. Good night.
conducting this class. Thank you.
Good
Good
night.
night.
Good night. Bye.
Yeah.
Bye.